Welcome, focused learners. Let's jump right into it. Today, we're locking down high-yield concepts for your exams with this comprehensive explainer on mucogingival conditions. We're going way beyond the basic textbook summaries here. We want to give you the precise structure details you absolutely need to confidently tackle those tricky board questions. So here is our study blueprint for today. First, anatomy and definitions. Second, the 2017 classification. Third, phenotypes, thick versus thin. And finally, diagnostic assessments. All right, Section 1, Anatomy and Definitions, nailing the basics. Let's get into it.
Okay, pay close attention to this key distinction because it trips up a lot of people. A mucogingival condition is basically your generic umbrella term. It describes the anatomy of the mucogingival junction and how it relates to the gingiva, alveolar mucosa, and frenula. Simple enough, right? But a mucogingival deformity? That's a significant departure from normal shape. And here's the absolute key differentiator for your exam. A deformity might actually involve the underlying alveolar bone.
Now, visually anchor these landmarks in your mind right now. Notice that distinct boundary of the mucogingival junction. It beautifully separates the attached gingiva from the looser alveolar mucosa. You literally have to be able to visualize exactly where that marginal gingiva ends and the attached gingiva begins. It's absolutely fundamental for diagnosing the conditions we're about to dive into. So here's a crucial point, and it's a classic trap on multiple choice questions. These deformities result from a deficiency or defect in periodontal tissue. They do not result from plaque. I repeat, they are not plaque-induced. So please don't let them trick you into selecting a plaque-related etiology when you see a mucogingival deformity on your exam. Moving right along to Section 2, the 2017 Classification Framework Official World Workshop Standards. You've got to know exactly where these sit on the classification tree. If we look at the overarching framework, they actually do not fall under periodontitis or your standard gingival diseases. Nope, they are specifically categorized under other conditions affecting the periodontium. And within that, the exact subcategory is mucogingival deformities and conditions. Lock that hierarchy into your memory. It's a guaranteed point. All right, here we have the precise list of the 8 specific deformities around teeth, as defined by Cortellini and Basada. They range from the overarching gingival phenotype all the way down to very specific localized issues, like an aberrant frenum position, a decreased vestibular depth, or the actual condition of the exposed root surface. Examiners love to pull directly from this exact list, basically asking you to identify which condition belongs to this category. Okay, Section 3, Phenotypes, thick versus thin. This is the core exam comparison. Listen to the stark clinical contrasts here. Thick phenotypes feature flat bony contours, meaning there's minimal rise and fall of the gingival margin. You'll also see thick bony margins plus a highly testable incidence of bony exostosis and tori. On the flip side, thin biotypes, they are incredibly delicate and heavily prone to gingival recession and soft tissue deficiencies. Just look at the flat scallop and that really robust tissue of the thick biotype on the left. Notice how the roots aren't prominent? That's because the bone completely fills that interdental space. Now compare that to the clear tissue deficiencies on the right. You can literally see the vulnerability in the thin biotype. The roots are often super prominent, and honestly, that tissue is just begging to recede if traumatized. Definitely grab a pen for this one, because you need to memorize this highly testable statistic. When assessed on the basis of gingival thickness, a thick biotype is more prevalent at 51.9%, compared to the thin biotype at 42.3%, with other types making up 5.8%. These are the exact numbers drawn directly from the source literature, and knowing them cold is going to give you a major edge. Let's lock in some more exact numbers for your boards. Keratinized tissue width, or KTW, ranges from 5.09 up to a really robust 6.65 millimeters for thick biotypes. Thin biotypes, though, they max out around 5.44 millimeters. But honestly, even more striking is the mean buccal bone thickness. Thick biotypes average 0.754 millimeters. For thin biotypes, that bone thickness drops to an incredibly fragile 0.343 millimeters. That is literally less than half a millimeter of bone. Let's wrap things up with Section 4, Diagnostic Assessments, Tools of the Trade. Consider this your ultimate cheat sheet for clinical diagnostics. When a board question inevitably asks you how to determine gingival biotype, remember this golden rule. Direct measurement and probing are reliable, while visual assessment alone is not. Your eyes can totally deceive you, but the physical probe, it definitely won't.
Here we can see transgingival probing. It's a highly reliable technique which assesses gingival thickness to the nearest 0.5 millimeters. Basically, using a standard periodontal probe, you physically pierce the tissue to contact the bone. It's direct, it's incredibly accurate, and, you guessed it, it's highly testable.
The crucial exam takeaway here is the trade-off that exam writers just love to focus on. Transgingival probing is accurate, sure, but it requires local anesthesia. That causes patient discomfort, and ironically, it can actually induce a local tissue volume increase from the fluid, which slightly skews your reading. Ultrasonic measurement, on the other hand, offers really high reproducibility within that 0.5 to 0.6 millimeter range, entirely without the needle or any tissue distortion. You'll also definitely need to recognize proprietary specialized tools, like the Hu-Friedy ColorView probe. This little tool simplifies biotype categorization visually right through the tissue. It's super clever. If you can actually see the color of this specific probe shining through the gingiva during your assessment, you are definitively dealing with a thin biotype. It brilliantly bridges that gap between just eyeballing it and physically probing. Finally, remember that while CBCT, cone beam computed tomography, gives you highly accurate bone morphotype measurements, you constantly have to weigh that beautiful diagnostic clarity against the real radiation exposure risk to the patient. Oh, and one last thing. A tooth's position in the alveolar process is a massive indicator. Buccal tooth positioning strongly correlates with both thin gingiva and thin labial bone plates. I'll leave you with this mock exam question to synthesize our explainer today. If a patient presents with a buccal tooth position and visual assessment alone is inconclusive, which reliable, non-radiographic tool should you use to confirm a thin phenotype? Think about those ultrasonic options or color-coded probes that avoid local anesthesia tissue distortion. Keep studying hard, trust the structured data, and you are absolutely going to crush this material.